Thanks for coming, everyone. Today we're going to be talking about Lisfranc injuries, and just in the interest of time, I've excluded pediatric Lisfranc injuries. So I'm solely focusing on adults for today, if that's all right. So we'll just go through the kind of the history of Lisfranc, talk about the mechanisms, classifications, and then talk about some treatments that we can offer. So who is Lisfranc? He was a Canadian surgeon, born in 1790, and he was in the French Revolution, the French-Canadian Revolution's army of Napoleon. Some interesting things about Lisfranc was that he studied under Dupuytren, which is quite interesting, and he was actually a gynecologist and described a whole bunch of other procedures such as removing the rectum or removing the cervix. And there's a lot of controversy depending on what articles you read. You'll hear how he described these injuries, but what he really described was an amputation through the midfoot, secondary to vascular injuries of people falling off horses, their foot being caught in the stirrup and dragged. So that's what he actually described, and you'll read a lot of different things about other things he described. And another interesting thing is that although he was a brilliant teacher and surgeon and scholar, he was apparently very difficult and arrogant man and had no close friends. So maybe that's why there's not a lot written about him. It's a difficult man. Now, Lisfranc is different from Lisfranc, who is an emergency physician who described this technique of immobilizing for midfoot injuries. We later orphed that. Anyways, so focusing on the anatomy, the Lisfranc joint is the tarso-metatarsal joint of the 5 metatarsals, and where they articulate the 3 cuneiforms and the cuboid bone. And it's very important. This joint is important for maintaining the arch of the foot. And then these trapezoidal, or triangular, I should say, shape of the metatarsal bases creates this Roman arch, which is important for the osseous stability, as well as the keystone of the second metatarsal, which, as you can see here, is the longest metatarsal in the body, and keys in to the medial cuneiform, the lateral border of the medial cuneiform and the middle cuneiform, and that is very stable, so that provides the osseous stability. And then we have to go on to the ligaments, which provide the additional soft tissue stability, and those two combined create what is a very stable arch in the foot and very, very important. So the Lisfranc ligament is what runs on the, it's an interosseous ligament that runs from the base of the medial cuneiform to the base of the second metatarsal. And that's found on the plantar aspect. And here are the tarso-metatarsal ligaments. And then on the opposite side, you have the dorsal ligaments. So interesting, the first and second metatarsal do not have any of these transverse metatarsal ligaments. It's solely attached by these strong ligaments that run from the medial cuneiform into the second metatarsal. And then all of these metatarsals have the tarso-metatarsal ligaments. And then they've done a series of cadaver studies looking at the strength of these ligaments. So the Lisfranc ligament in this whole complex, when taking into account the dorsal, the plantar, and the Lisfranc ligament, the Lisfranc is by far the strongest ligament in the foot in this tarso-metatarsal region, followed by the plantar ligaments, and then the dorsal ligaments are the weakest ligaments. And then that is important for the mechanism and the patterns of injury we see, is that normally the dorsal ligaments will be the first ones to fail, and it will be the Lisfranc ligament, which will be the last one to fail. And then coming back to the original Lisfranc, why there's these vascular injuries is the dorsalis pedis. Its traditional course should run in between on the dorsal aspect of the foot and running in between the first and the second metatarsal right there.
Oh, that's
and then that can be injured. So the incidence of Lisfranc injuries, this is American, is quite rare. It's only 1 in about 55,000 people per year, and about, in the US, 0.2% of all fractures. And it is commonly missed. They reckon up to 40% are missed at initial presentation, and at least 20% are going to be not treated for at least a week. So people will come into emergency, they'll have an injury, a sore foot, get an x-ray, go home, and continue to walk on what is actually a Lisfranc injury, versus the missed injuries where they're not diagnosed, but they'll be put in a back slab and sent to us in clinic. And then the problem with missing these is that it is, leads to subsequent pain and arthritis as the foot can collapse, and then you can get into planovalgus foot. This is foot deformities. This is at the extreme end. But essentially, it is a cause. Maltreatment of these injuries causes a painful foot, and that's what we're trying to avoid. So the mechanisms, there's two. We classify them into 2 different groups: either direct or indirect forces, and indirect being much more common. So direct forces, as you can imagine, depending on where those exact forces are going to be laid, you're going to have different displacement of the metatarsals. And you can see by those arrows there, and that makes sense. If the force is on the dorsal aspect there, it's going to displace the fragment plantar-wise, versus if the forces are laid more proximally, the metatarsal will be displaced in dorsal-wise, which is probably much more common.
Actually, that diagram was really interesting. The big arrow at the bottom.
Which this one?
Yeah.
Probably. Well, I think you could have either way with the big arrow.
Basically,
Yeah.
I mean, you get a lot of guys who get this rank with a heavy object like
Yeah.
doors.
And the other one's
New
based.
doors.
Yeah.
Weak and opposite. So why the force coming down top of it and it's saying
Yeah.
force right on the ground.
Absolutely.
That's the other way is where you catch your toe against something as you go up. You hit your foot and it's forcing it.
So yeah, so these injuries, car
Well, I
accidents.
mean, the arrow then should be right at the end of the toe.
That's the next. That's
The indirect should
the
be right.
indirect coming out.
And then so this is looking at indirect mechanisms.
Yeah.
Oh. So indirect, which is much more common. So
Oh, I see. Yes, I thought
so the forces aren't directly laid upon the tarsal metatarsal area.
So the whole slab before is directly.
the whole slide before was direct. Yeah, thank you. Yeah, that's right. I see. Sorry.
So indirect is more common, and this is a prime example. This is the position of danger of when someone's in a forced or extremes of plantar flexion, and then they get the dorsiflexion of their toes, and that loading up of that foot. And again, the dorsal ligaments will fail first, and then the plantar ligaments, and then the Lisfranc ligaments. But having a look at this, the most common, you'll see the metatarsals are displaced onto the dorsal aspect. And so common injuries, about 1/3 of these are low velocity trauma, so sporting injuries, things like that. And we'll talk about that in just a second. And then, but 2/3 of these injuries are from severe trauma, people falling from heights or involved in motor vehicle accidents. And you can imagine people jamming up against the steering wheel during a collision. Interestingly enough, and this is close to my heart because I played a lot of football when I was at high school, is that in college football they've done studies that show there's a 4% incidence per year in college football of Lisfranc injuries. So that's a lot of people having Lisfranc injuries. And what it happens is, again, it's in that position of when they're running and then they have their foot in forced plantar flexion, and then they're tackled, and then that forced axial loading onto their foot causes the Lisfranc injury. So it's very, very common in American footballers, probably because it's one of the toughest games around.
They allow it. that the way they tackle down at the bottom there?
Well, you've got to wear pads. Yeah. So the workup, obviously, physical exam is very important. Swelling. So remember, we're saying that 20 to 40% of these injuries are missed. So when you see gross swelling in the midfoot region, alarm bells have to go off on these kind of mechanisms, and you have to at least immobilize it and start thinking about a Lisfranc injury. The plantar ecchymosis is a pathognomonic sign, and it's important that we rule out compartment syndrome. Now, compartment syndrome is very rare. Speaking to James, between the two of us working at the two major trauma centers, we didn't see any foot compartment syndrome, so it is rare, but it's something that you do have to be aware of because the swelling is quite severe. Now, if these fractures are dislocated, still dislocated, they have to be reduced quite quickly, and that needs to be picked up.
How many were measured though?
Oh,
How many did you see actually measured?
minimal. I know at the Royal Melbourne, they tend to go on everything's clinical diagnosis, and I haven't put any needles in foot, it's just calves.
The foot's just up like a foot.
Yeah.
They can't move their toes.
Overall, when I was there, they decided not to release it anyway. Yeah. Deal with it actually. That's what I'm measuring. They were measuring that short.
Yeah. So, and this is important for the residents and medical students back there. Working up, so x-ray, they need the an AP, a 30-degree oblique, and a lateral view. And the one thing that we always do very poorly is weight-bearing views. The foot is a dynamic joint. If it's not loaded up, we're not seeing the true instability of the foot. So if the AP, lateral, and oblique are normal, but they're swelling, you need to consider getting a weight-bearing view and explain to the patient the importance of trying to have even distribution of weight on both their feet. So that way you can take an x-ray of both of their, an AP x-ray of both their feet at the time, and you can have a comparative x-ray, as well as see that dynamic instability. So this is something that's poorly done probably by us registrars in clinic, but particularly in emergency. And then the next debate is whether we should go, if there's a level of suspicion that the x-rays are normal, should we go to MRI or CT scan? Now, MRI has been shown to be extremely sensitive with regards to instability of the foot. And there was one study that I just read the abstract of that showed that in over 100 patients, when they correlated the MRI findings with the intraoperative findings, they had an over 90% sensitivity for, if they called it a grade 2 tear of the Lisfranc ligament, then the foot was unstable. So MRIs are very good at picking up bony edema, as well as ligamentous injuries, and predicting the instability of the foot. And that's the important thing, is if the foot is unstable, then we probably should be thinking about fixing these. So that's the real benefit of MRI, is that it's going to show you some level of displacement, if there is any. But if we're looking for these subtle Lisfranc injuries, it's also going to pick up the ligamentous injury and be a better predictor with regards to the instability of the fracture. So maybe there's some suggestion that we should be doing MRIs before CTs, but CTs obviously are so easy to do, so if we're concerned, we just chuck them in the CT scanner. The worry of the CT scan is that it's not a weight-bearing film. There is no weight-bearing CT available, so the joints aren't loaded. So you may be artificially led to believe that everything is in a good location. And bone scan, probably used more in general practice to pick up a bit of edema or late presentations, but I don't think it's particularly relevant in our clinical practice. So clinical findings, again, any kind of swelling over the tarsal-metatarsal region should raise suspicion. And this is a picture of that plantar ecchymosis. And then that's pathognomonic. So if you see this, guys, you should be very concerned that there's a Lisfranc injury. So getting on to the classification system, Kinu and Kuss originally described this in 1909, and they divided it into 3 different groups. One was homolateral, where all of the metatarsals are displaced in the same area. in the same direction, I should say, isolated where only part of the metatarsals are displaced or injured. So here's an example of the first metatarsal being displaced, or divergent, and that's when some of the metatarsals go in one direction, some of the metatarsals go in another direction. The problem with all of the classification systems that they found is there's no strong classification system that directly correlates to the operation, that, you know, whether we should treat these operative or non-operatively, or to the outcome. So classification is probably a little bit more academic with regards to it actually guiding treatment or prognosis. And then this was later modified by Hardcastle and various others into types A, B, and C. And that, again, encompassing, they talk about incongruity so if all of the metatarsals are displaced in the same direction, it's going to be an incongruent Lisfranc region. Partial is again going to take in some of that isolated, so some of the metatarsals are going into different directions. And then divergent is quite clear. I should say that later Myerson in about 2000 described the columns, trying to separate the foot into columns, and maybe that this is a better predictor of how well they'll do. And then one is there being the medial column, which is basically the first ray, so the first metatarsal, and the medial cuneiform being the medial column, the middle column being the second and third metatarsals, and then the middle and the lateral cuneiforms, and that being the most stable column of the three columns. So if there's any injury to that column, then it should be fixed along those lines, because that's the most important, that has to be stable. And then the lateral column being the fourth and fifth metatarsals and the cuboid in their articulation there. And that having the largest flexibility in its natural sense, so being the less important to fix. So the three-column classification is much newer, and we're probably learning more about that. So radiographically, plain film radiograph, so on the AP, you should be looking at the first metatarsal lining up with the lateral side of the medial cuneiform. And so that's the line that we should be looking for. And then this is an oblique view for the residents, and then we should be looking at the third metatarsal lining up with the lateral cuneiform. And so these are the lines that we're looking for. And then on the lateral view, we're looking for the metatarsals lining up with their appropriate cuneiforms. And then here's obviously some radiographic pictures. You can see that the metatarsals are no longer aligned, so that's indicative of a Lisfranc injury. And I think that there's a fracture there, but I'm not sure. I'd probably get an MRI on that one, or an ultrasound. And then this is the other one that we should be looking at as pathognomonic as well, is this Fleck sign. When you see this little fleck of bone in the space between the first and the second metatarsals, and that's indicative of the Lisfranc ligament itself avulsing a flake of bone, either off the base of the second metatarsal or off the medial cuneiform. So this is something that you can pick up in emergency. And if you look, that you can see that this second metatarsal isn't lined up perfectly in this mortise, and so that's again indicative of that kind of thing. And here's a picture of some CT scans. You can see this is a good comparative view, and you can see these dorsal or the plantar fragments of the second metatarsal base, and then the divergence here of the first and the second metatarsal. And here's an MRI scan where it shows a lot of benefit. You can see the bony edema here, and you can see the tear in the Lisfranc ligament. So MRI is extremely sensitive and a very good test to be used when looking for Lisfranc injuries.
Is that the Lisfranc ligament practice?
Yeah. The Lisfranc from the medial cuneiform to the base of the second metatarsal. So, but that second metatarsal, you'd imagine it should be there. Yeah, I think this is, I think that must be fracture there. That's a,
That's a slice where the joint, you can't see the joint.
yeah. The same, yeah, it shouldn't have. So that was what was described in the internet picture that I found. So, and then this is out of a JOS, the JOS review that came out in 2010, and shows a basically a stepwise path for investigating and whether we would fix them. So physical exam, if it's unstable, on the physical exam you're looking for what they call the piano key sign. So if you can bounce the first metatarsal, the second metatarsal up and down like a piano key, and that's unstable, or, pardon me?
Get a copy.
Yeah. And then, so if the x-rays are normal, we should get weight-bearing views, and then if they're normal and there's a level of suspicion, then we should be looking at MRI, according to this JS article. And then if there's any divergence or displacement of greater than 1 millimeter, they talk about, then we're talking about fixing. And they talk about 1 millimeter of subluxation. And then if there's this is interesting, so if there's edema and no ligament tear on the CT scan, and the stress, or, so the CT is normal, there's edema in the bone but no ligament tear, then we should be, the next step is to consider taking them to theater for an EUA, plus or minus fixation. But this group of authors strongly advise that we should do everything we can to diagnose the injury before we take them to theater to do an EUA. So treatment for the non-operative regime, again, is when everything is anatomically aligned and we're convinced that there's no Lisfranc ligament injury. And I think this is where it gets a bit debatable. It's on the MRI. If there is this Lisfranc injury, should we be fixing them all because it's a sign of instability? Or should we consider non-operative treatment? I think that hasn't been well tested in the literature. But we have to be very careful about when choosing to treat these patients non-operatively, because just normal x-rays and normal CTs doesn't mean that there's lack of instability. And certainly in all the literature I read, everyone seemed to agree that purely ligamentous injuries take longer to heal than ones associated with bony fractures. So this is just one treatment regime. Is if you're going to treat one natively, you hold the forefoot well supported in a cam boot. You can put it in an arch support for 6 to 10 weeks, and weight bearers tolerate. And it's really important, if you're going to treat them non-operatively, you need to have weight-bearing x-rays at 2 weeks to make sure that they're not displacing at those stages. And I think, again, this is something that in my practice I haven't seen done terribly well. And then if they're lucky enough to have a non-operative regime, it's only about they say a 4-month recovery until they can get back to active sport. Now, surgical treatment is designed for any of these unstable fractures, or the literature clearly says above 2 millimeters of displacement. Everyone seems to be in agreement that we should fix them. And then there's other groups that say 1 millimeter of displacement or subluxation of any of these bones or joints in the Lisfranc region should go on to being fixed. Or if they're unstable, obviously if they're divergent on weight band films. So operative management, obviously we've talked about the swelling. The foot swells up very much. It's hard to close. Wound issues prevalent in the foot. So we need to be we need to wait for the swelling to come down. And the literature, again, kind of everyone talks about it. It's never been tested that you should do it within 2 weeks. But this group, the group that did that JS article also reported that some people they couldn't get onto until up to 6 weeks. And they've had numerous patients that they fixed at 6 weeks and have still had very good results. So we can line up for good results, fixing them up to 6 weeks. And then the other thing that we need to be, accuracy in your reduction is very important. All right. So the literature again supports that people who have very anatomically reduced Lisfranc joints have success rates in the literature from good to excellent results from 50 to 90% of people who have anatomical reduction are going to have a very good result, versus people who have poor reductions there's 17 to 30% reported incidence of good results. So that's a very wide spread, but if you can only get up to 30% good results with a poor reduction, reduction is absolutely essential when going for operative management. And then when we do go on to operative management, we have to talk about closed reduction and percutaneous pinning. Is that acceptable? And then talking about open reduction. And should we put in transarticular screws? Should we put in bridging plates? Should we do a primary arthrodesis? Or some of these ligamentous injuries now, people are treating with endo buttons or tight ropes to try to replace that ligament. So when we talk about a closed reduction, again, the issue is that those dorsal ligaments, as we know, are weak and they're invariably ruptured. And we've all seen them in open operations as they flick down into the joint and can prevent a good reduction. So percutaneous pinning needs to be carefully considered when doing that. The problem is there's no good randomized control trials or any studies that talk about percutaneous pinning versus open fixation for all cases. Now there's been plenty of good reports of people doing percutaneous pinning with a happy reduction on table under II and having good results. So the people who believe in percutaneous pinning will do it for that reason, because they've had good results and there's reported good results now. But then there's a lot of believers who think that everyone should be an open reduction. There's small flakes of bone. There's ligaments that invariably get into these joints and prevent a good reduction. We know how important good reduction is. So why aren't we doing these for all patients? Transarticular screws, there's some concern of when you're actually drilling through a joint, and then you have to expose all of these patients to an operation down the track. Now, it doesn't have to be a screw, it can be a K-wire, but it's been clearly shown in the literature that screws are much stronger than K-wire as far as holding the stability, especially for the first, second, and third metatarsal, tarsal-metatarsal joints. Bridging plates is another thing that we need to think about. Are we damaging the joint that's already damaged by putting a giant screw through that? And should we be doing that? Is that going to lead to arthritis down the track? Where a bridging plate can keep clear of that. Bridging plates are advocated especially when there's severe comminution of the joint, because you can get a good reduction and hold it well without doing any further damage. And then arthrodesis is the next stage. Now, there's been numerous studies that have directly compared operative fixation, randomized studies, so open reduction internal fixation versus primary arthrodesis. And in all of these studies, the follow-up is about to 4 years. There's numerous of these studies, 4.5 years. Generally show that primary arthrodesis of the affected joints, of the tarsal-metatarsal joints, have better functional scores, earlier return to weight bearing, and less pain. So there's probably some suggestion that primary arthrodesis do better. But again, these are short-term studies of only follow-up of 2 to 4 years. We need to know how they're going to be in 15, 20, 30 years. If these are happening to people who are playing American football or car drivers, their problems are going to happen when they're 50 or 60. And then these are just new kind of techniques that haven't been well described and compared in the literature. So this is an example here of you can see the divergent and the displacement here in the second metatarsal. So this was fixed. This is the Lisfranc screw replacing. Keep going. All right. Very good. And then this is just showing that we have to remove the screws at 4 to 6 months. Here's a picture of this joint being displaced in open operation and being well reduced. That's the mortise of the second metatarsal. Here's some example of bridging plate. You can see the comminution. And then here's a series of endo buttons, one coming from the medial to the middle cuneiform and one replacing the Lisfranc ligament. So in summary, I think that Lisfranc injuries are very, very commonly missed, and we need to have a higher suspicion because they do lead to significant problems and pains in the midfoot. Maybe we should be considering MRI as our second line of investigation over CT scan. I think it's essential that when you do go on to operative fixation, you need to consider open reduction and anatomical reduction, because that has been clearly shown to be the most important thing. And then we'll look into the future to see what these endo button and tight ropes do. The benefit being that you don't have to do a second operation. So this one's for Scotty. Thank you.